And joining us now to talk about DENOSA's statements about health inequality is Sibongiseni Delihlazo from DENOSA, the Democratic Nursing Organization of South Africa. A very good evening to you, and thank you so much for speaking to us. Perhaps let's just first start with a layout of the South African health system. I mean, it is currently engaged in what is said to be a complex project of establishing universal health coverage that will ensure the system's ability to deliver comprehensive care that is accessible, affordable, and acceptable to patients and families across the board. Are you saying this is not happening fast enough?
Good evening to you, and good evening to the viewers at home. Indeed, as you mentioned, I think as you outlined, we are headed for an era where everybody would have access to quality healthcare based on their healthcare needs, on their health needs. We're very concerned as DENOSA. We don't think the pace at which we are preparing the ground for the ushering in of the national health insurance is fast enough. Yes, we've got 2026 where we'll be introducing the NHI, but of course we'll introduce it gradually. But from DENOSA, from our perspective where we are, we feel that the institutions, because institutions must be prepared. You must prepare institutions in terms of personnel, in terms of the upgrade in the infrastructure, and the cleanliness and the general environment must be welcoming for healthcare facilities. And that is not happening, which is a serious case for us. Of course, NHI is not going to arrive like manna from heaven. It is going to be utilized in the institutions that we have in terms of the public sector, but also the private sector, the private healthcare institutions will also be in line to provide NHI. Our fear is that once you start NHI with the few institutions which have been upgraded in terms of their infrastructure, the personnel, the equipment and resources, you are likely to provide NHI services in institutions that are now called private institutions. Now, that means people may be flocking to those private institutions because no institution is going to provide national health insurance service if it has not been accredited by the Office of the Health Standards Compliance. Now, that office, for it to accredit you, you must satisfy a criteria in terms of your cleanliness, the upgrade in your infrastructure. This is what concerns us, that the pace at which we are preparing the ground for the ushering in of NHI from the public sector side is making us extremely worried, because if you look at many populations in our townships and in the rural areas, that is where most people need healthcare services. And if you don't have those institutions upgraded so that they could be in line and could meet the bar that the NHI will be setting in terms of what level you should be at for you to be able to provide NHI services. That concerns us because we feel that many communities may be deprived of the quality healthcare that we are saying we need to get as a country.
I was just listening to a response on the concerns that you've raised, and the person that was speaking there, I think was a doctor or government spokesperson, basically saying that we need to start looking at primary healthcare level first, saying wellness clinics. But I'm just wondering, are those the only structural problems that are preventing us from achieving universal healthcare coverage? Because I'm thinking of this case of Jeremiah Mwecha in Bloemfontein, who died after being turned away from a clinic in Bloemfontein. Is it attitudinal changes, or is the system itself just generally broken?
It's essentially a system. I think we need to overhaul our system. If you remember, our healthcare system in South Africa is a curative system. It's not a preventative system, healthcare system. Now, by national health insurance, which generally essentially is the re-engineering of the primary healthcare, we've got, for instance, a situation where our healthcare system waits for a patient to present themselves in a secondary or even a tertiary institution. And this is because in terms of our primary healthcare institutions, there are a number of system issues that need to be looked into, a number of opportunities that must be unlocked. For instance, you've got many clinics that should be providing 24-hour service for communities. But Many of those clinics are operating for 8 hours simply because there is not enough staff, there is not enough equipment and resources. Now, for us to get to the national health insurance level, it means that we must try to change our healthcare system towards primary healthcare. It must be primary healthcare focused so that as a system itself, it is focused more on preventing illnesses rather than a system that is only designed to accept illnesses when they are at an advanced stage where you only manage them or you cure them. Or if you are not able to cure them, you rehabilitate, which is at the level of palliative care, higher level. We don't master the area of primary health care. We are starting to look into that. We are hoping, of course, as DENOSA, that the pace at which we do that will show that we are passionate about it, because the primary health care is community focused. It means healthcare workers must go out to communities. They must screen community members. They must sit down with families. If there's a family member who's got a certain illness, they must screen all family members. Unfortunately, with the shortage of staff that South Africa is faced with in terms of healthcare professionals, our system currently is not able to go out to communities. Going out to communities is one way of managing, and that is preventing illnesses. Because once you screen and you identify areas, you're able to manage them.
Mr. Delihlazo, let me jump in here because I'd like to get some points in as well. And that is, from what you're saying, you talk about the training of staff at community level, but I'd imagine that there needs to be some empowerment of communities themselves. If you think about how in the past, if one was looking for beyond the indigenous knowledge systems, for instance, do you think that there needs to be a focus on that? Do we need to empower communities more, for instance? If we're saying South Africa's biggest problems are HIV/AIDS, multi-drug resistance, TB, and we're also seeing a growing burden of chronic communicable diseases. So how do communities empower themselves in terms of prevention?
Well, that can be done with collaboration between the Department of Health and also with community organizations and community members. And in our settings, in our community settings, our settings are different. You go out to communities, I mentioned, and for instance, you could go out to the chiefs in the case of rural areas. And you obviously educate communities about a particular illness, a particular virus, and you mentioned the issue of HIV. We've got a serious issue with TB, especially in the mining areas. And part of that community education will mean that healthcare workers must go out to communities. Now, we are starting to accept the new cadres in the healthcare services, your community healthcare workers. Those are the cadres that must go out to communities, and this is what the government is trying to prepare. But this is what we feel we need to fast-track that process to ensure that we are ready for 2026 when we have to usher in the national health insurance.
And the fact that nearly half of the public health resources are allocated to district health services, which obviously include primary healthcare clinics, community healthcare centers, and district hospitals. The funding model of the NHI has been questioned. How would it then prioritize efficacy in these areas, in your views?
Well, this is what concerns us, because if you look at the primary healthcare level, you talk of clinics, and in our communities, there are more clinics than there are hospitals. And for a facility, as I mentioned, to be able to provide national health insurance, that must satisfy a particular criteria. But the government must also try to ensure that the ground is being prepared to ensure that by the time we reach 2026, those institutions are at least at an advanced level of alignment so that they could be able to provide NHI. We are very unhappy with the pace at which this is being done. And as I mentioned, I feel that many communities may miss out on the NHI, and we may find a situation where there could be overcrowding. If people want to go and get NHI services, look at the UK, the shortage of staff, is a serious issue that we feel could be one way of addressing it. Yes, the government in South Africa is trying to push a model that is called ideal clinics model. It's whereby you say a clinic, for a clinic to be ideal to provide NHI service, it must strive to improve in these areas. This was being done at some point during the piloting phase of NHI, if you remember, in different districts where facilities were assessed and various areas of needs were identified. Some of those were done, but after the piloting period, we feel that the pace at which that was done, it has somewhat stopped. Now, even those who have passed the criteria at the time during the piloting stage, you find that at the implementation level, when you assess, you still find that there are still many areas that need to be improved.
Sibongiseni Delihlazo, I'm afraid we have run out of time, but we do appreciate your time from DENOSA speaking there about inequality, particularly in the health sector.